Hello again. I just thought I'd start by sharing my mobile phone with you. I told you about our beta version of Tuhi, the scribe, which is so fantastic. And I have this little message saying Tuhi crashed. But I can't get rid of it. I've been tapping away to get rid of this message and it won't go away. So that's crashed too. Because I'm really trying to start. I think it's eight minutes, is that right? I can't do it. So could you give me a yell when 8 minutes is up, Jules? It's dead. Thanks to Tuhi. It's a pleasure to be here again. Just to demonstrate how far I've come to this meeting. Hamilton is a very long way from Orlando, but the world is so small these days that it only takes the tiniest fraction of a second to get information from anywhere you want. Today, I'm talking about our electronic referrals from 2016 to 2025. I started with teledermatology in 1995. So I had a lot of experience before the current system where we have templates, data collection and analysis, and we're really trying to develop strategies to reduce response delays. We don't have 6 months patients waiting to see us, but we have had up to 3 months patients waiting for a teledermatology response. And what is the potential for AI to enhance referral management? Well, we have a dermatology crisis. In 2012, it was recognized there was an extreme shortage of dermatologists in the public sector, with 16 full-time equivalents, inadequate training positions. But in 2024, it's much worse than in 2012. In the same time, the population has increased from 4.4 to 5.4 million, and they're older. Older people have greater health needs. In primary care is the place where most patients with a skin disease receive their advice. Yet, New Zealand GPs have had very little training. In fact, in medical school, in their 4th year of training, which might be the first week of clinical medicine, was the case this week, we pulled our hair out with the 4th year medical students who didn't know the difference between a papule and a plaque. But that's all they get, 2 half days in the whole of 6 years of medical school. So it's not surprising that GPs don't have the training, qualifications or experience, and yet handle what used to be said to be 85% of dermatology, but it's now much nearer the 100% than it was. So this is our whole workforce for 1 million people. We've got 5 dermatologists, 2 GPs, the first one started this week, the second one started this week. We can't get dermatologists, so we're training up primary care physicians. And we have 3 registrars in training. We've had 50,000 referrals since 2017, which is when the statistics related to templates and we started gathering the information. The number of referrals, not surprisingly, is much greater in 2025 than it was in 2017. According to the census population, we should have a lot more young people referred than is the case. The census says young people are 21% of our local population, that with referrals were 10%. And not surprisingly, the opposite for older people. The census says 16% of people are over the age of 65, but 40% of our referrals for that age group. Ethnicity variation. Most of our referrals are in the New Zealand European ancestry population, with only a small proportion of Maori, who make up 24% of the population, and Pacific, who make up nearly 10% of the population. A lot of that is explained by skin cancer referrals. So we use a system called the BPAC referral system. Best Practice is a charitable organization that works on behalf of primary care. The referrer selects dermatology, one of two templates, either for suspected skin cancer or other, and how urgent they think the referral is. There are 3 urgent categories and 3 not so urgent categories, and we respond. And we respond to the 3 urgent categories within a day or 2, but the rest wait. We can decline, for example, the images are inadequate. We can accept them directly for a clinic, or the rest we accept as a non-contact first specialist assessment, otherwise known as teledermatology. But for coding purposes and funding purposes, it has this NC, FSA, and it's paid almost as well as seeing the patient face-to-face. That's to the department. It isn't to the personal dermatologist. I'm salaried. So this is the interface I see. The colorful stripes on the left tell us how many images are attached and the urgency assigned by the GP. You can see there are 2 different triage queues, one for SSC or suspected skin cancers, and the others are the general dermatology. So we know that referrer urgency doesn't match what we think as dermatologists should be the priority. So for acute referrals, many of them are non-urgent seborrheic keratoses. For the routine referrals, some of them are melanomas. Does our advice improve patient care? Of course it does. For suspected skin cancers, we avoid unnecessary excisions and biopsies, so we end up with low benign malignant ratios in primary care in the Waikato. We have shown that we have high melanoma in situ to invasive ratios, and excisions are much faster in the primary care setting than is possible at the hospital, and they're also less expensive. For general dermatology, we replace unnecessary investigations and treatments. But the patient has to go and see the GP, and that's a private setting. Although it's subsidized according to various parameters, they do have to pay to do so. Some of them are insured, but most are not. So we showed in 2016 that by adding templates, the referral information improved massively. We learned the duration of the rash. We learned the site of the lesion. We know that we must have good images to help diagnosis and treatment. And like Paola, I have spent a great deal of the last 20 years offering GPs training, and the best training is on the job. So we decline those with bad images, and those that might just have one bad image, we'll explain exactly what we expect next time, and we get it. They learn fast. We heard about the problem with Epic not accepting large files. That is sometimes a problem from some of our referring GPs, but they can compress the file without losing the resolution or the clinical quality. We describe the history and images, we recommend a care plan, we provide follow-up recommendations and add patient information, which goes to the patient at present by snail mail. The GP selects from, oh, we're over time. Sorry about that, I'm going to carry on. The GP selects one of the, all those tabs and fills them in by a menu-driven system. We see the template and we answer in 3 boxes: the problems, the goals, and the patient information. So in our referrals last year, typically we had about 25% of referrals in the rapid system, and the rest were the routine ones that had to wait. We only saw 8% of patients in the clinic. The rest were sent advice by teledermatology. But in March last year, 800 referrals were waiting for up to 12 weeks for us to answer. So how does technology help? Well, I'm grateful for a Canadian medical student who is visiting us for an elective, who pointed out we could do better using text blaze. And the text blaze shows us different templates. We design them, they're constantly changing, so it's an agile system we can fix on the day, and we can use various drop-down menus and toggle fields. So now we can answer a referral with the same or better, more consistent advice by reading the referral, filling out a template, and automatically filling in the result. With text blaze demonstrating a great deal of time has been saved. We can also train our residents much more quickly. And we've got down to a 4-week delay. Still pretty bad, but it's a lot better than a year ago. So how could AI help? AI could help with image capture. AI could suggest a diagnosis. AI could prioritize so that the melanomas didn't have to wait. AI could generate the care plan and involve the patient. We can reduce inequities for our Indigenous population. So is a dermatology digital hospital possible, and can we achieve this anytime soon? We hope so. We're planning to use our images to test AI differential diagnosis using both close-ups and dermoscopy images, and to determine user acceptability, the referrers and the dermatologists and the patients. In summary, we get about 700 referrals per month, 40% wait more than a month for a response. Most of the rest get, most of them get diagnosis, care plan, patient information, but we've pushed the burden of care to primary care. We hope AI will provide more benefits, and this is my project team and collaborations. Thank you.